Assalamu alaikum. I am Dr. Refat Tabassum, Associate Professor, Bashundhara Ad-din Medical College, South Keraniganj, Dhaka. Today we are going to discuss about bilirubin metabolism. What is bilirubin? Bilirubin is a orange-yellow bile pigment formed principally by breakdown of the heme portion of the hemoglobin after termination of the normal lifespan of the RBC. Fate of red blood cells. The lifespan of the blood stream is about 120 days. The sentient RBC are phagocytized by macrophages of reticuloendothelial system in spleen and liver and are lysed. Normally the lysis occur extravascularly, but it can also occur intravascularly. In extravascular pathway, RBC for destruction it occur in the liver, bone marrow and spleen. Phagocytosis and lysis occur of the hemoglobin, and it is divided into heme and globin. The globin portion which is goes to the amino acid pool, and heme portion is when go to the converted into bilirubin and then excreted. Degradation of heme to bilirubin. 80% of heme is derived from the RBC, another 20% from myoglobin, cytochrome and catalase. In normal adults, 250 to 300 mg of bilirubin is formed daily. Normal plasma concentration is 0.2 to 1 mg per deciliter. Formation of bilirubin. A macrosomal enzyme, namely heme oxygenase, utilizes NADPH and oxygen and cleave the methylene bridge between the two pyrrole ring A and B to form bilivardin. Bilivardin is hydrophilic and green in color. Simultaneously, ferrous ion is oxidized to ferric ion. Bilivardin methylene bridge between the pyrrole ring C and D are reduced to methylene group to form bilirubin. 1 gram of bilirubin on degradation finally yields about 35 mg of bilirubin. Transport of bilirubin to liver. Bilirubin is lipophilic or hydrophobic. It is released from reticuloendothelial cells to the blood and from bilirubin albumin complex and transported. Bilirubin is taken up by hepatocyte in the liver. Conjugation of bilirubin. Uptake of bilirubin by liver is mediated by carrier protein, receptor mediated endocytosis. On a smooth endoplasmic reticulum, bilirubin is conjugated with glucuronic acid. The reaction is catalyzed by the enzyme bilirubin glucuronyl transferase. The result will be formation of bilirubin mono and diglucuronides. In general, 80% of diglucuronides and less than 20% is monoglucuronides are formed. Excretion of bilirubin in bile. Conjugated bilirubin is water soluble and excreted by hepatocyte into biliary canaliculi against the concentration gradient. It is an active energy dependent process. More than 98% of the bilirubin enter into bile is conjugated. Here is a flow chart of normal bilirubin metabolism. Fate of bilirubin. Bilirubin glucuronides are hydrolyzed in intestine by specific bacterial enzyme beta glucuronidase to liberate bilirubin. Bilirubin is converted into urobilinogen, which is colorless, by bacteria in the gut, a small part of which may be reabsorbed into the circulation. Urobilinogen can convert it into urobilin, which is yellow in color, is in the kidney and excreted. A major part of the urobilinogen is oxidized to stercobilin, which is excreted in the feces and gives the characteristic brown color of the stool. Some stercobilin may be reabsorbed by gut and re-excreted either by liver or kidney. Now jaundice. Jaundice is a clinical condition characterized by yellow discoloration of the skin, sclera and mucous membrane due to excess accumulation of the bilirubin in the plasma. Jaundice is actually a symptom, not a disease. The reference range of total bilirubin is 0.2 to 1 mg per deciliter. about 0.2 to 0.6 milligram of bilirubin is unconjugated, while 0.2 to 0.4 milligram per deciliter is conjugated bilirubin. Now, classification of jaundice. Jaundice is classified into mainly three major groups: hemolytic or prehepatic jaundice, hepatocellular jaundice, and obstructive jaundice or posthepatic jaundice. Hemolytic jaundice is due to excess hemolysis of erythrocyte in the blood, and in hepatocellular jaundice due to liver disease, and obstructive jaundice due to blockage of the bile duct. Major cause of jaundice. For prehepatic jaundice, there are hemolysis by autoimmune disease, incompatible blood transfusion, malaria and sickle cell anemia are the causes. In hepatic jaundice, hepatitis, liver cirrhosis, biliary atresia are the main cause. And post-hepatic jaundice, gallstone, biliary stricture, carcinoma of the head of the pancreas and cholangitis are the main cause. Now, hemolytic jaundice. Hemolytic jaundice results from excess production of the bilirubin following hemolysis beyond the liver capacity to conjugate it. Liver possesses a large capacity to conjugate bilirubin, more 3 gram per day, against the normal production of the 300 milligram per day. Jaundice developed due to rapid hemolysis, liver then unable to conjugate the such a rapid rate. More bilirubin is excreted into the bile, leading to the increased formation of urobilinogen and stercobilin. Characteristics: elevated plasma unconjugated bilirubin, no bilirubin in urine because unconjugated bilirubin is water insoluble, more urobilinogen in urine, dark color of feces due to high content of stercobilin. Hepatocellular jaundice. Hepatocellular jaundice is caused by the damage of the liver parenchymal cells. It reflects the generalized liver damage or dysfunction. Hepatocellular damage leads to impaired uptake, conjugation or excretion of the bilirubin. Characteristics: increased level of the both conjugated and unconjugated bilirubin in plasma, excretion of the conjugated bilirubin in urine, and increased activity of the ALT and AST in the serum due to damage of the hepatocytes. Obstructive jaundice. Obstructive jaundice is caused by an obstruction of the biliary tree that prevent the passage of the bile into the intestine. Characteristics: plasma bilirubin is conjugated and bile acid are accumulated in the plasma. Bile acid is excreted in urine, characterized by pale colored stool and dark urine due to increased conjugated bilirubin in urine. In a complete obstruction, urobilinogen is absent from urine. Alkaline phosphatase are increased in plasma. Feces contain excess fat due to impaired fat digestion. Now, here is a chart which is for the differential diagnosis of the different type of jaundice. In case of hemolytic jaundice, serum bilirubin is increased which is unconjugated, and in hepatocellular both conjugated and unconjugated bilirubin are increased, and in obstructive jaundice conjugated bilirubin is increased. Vandenberg reaction indirectly positive in hemolytic jaundice, and in hepatocellular jaundice it is biphasic, and in obstructive jaundice it is direct positive. Serum enzyme ALT, AST, alkaline phosphatase are normal in hemolytic jaundice, and alkaline phosphatase is increased in obstructive jaundice, and in case of hepatocellular jaundice ALT and AST are increased. Bilirubin in urine is not excreted in hemolytic jaundice, but is excreted both in hepatocellular and obstructive jaundice. Bile acid in urine is not excreted in hemolytic jaundice, but present in hepatocellular and obstructive jaundice. Urobilinogen in urine is excretion increased in hemolytic jaundice, but in case of hepatocellular and obstructive jaundice it is normal or decreased. Thank you all. Assalamu alaikum.